Doctors and professors, now we start the next session. Can drug therapy and classical local treatment coexist? Chaired by Dr. Jia Fan and Dr. Tatsuya Yamashita. Please.
Okay, let's start the next session. HCC2, can drug therapy and classical local treatment coexist? I'm Tatsuya Yamashita from Kansai University, Japan, and moderator Jia Fang is not still here. And discussant is Teiji Takuya from Japan.
Yeah, I'm Teiji Takuya from Fujita Health University in Japan. So let's study in this session with active discussion.
Okay, our program is a little bit modified, and the first speaker is changed to Dr. Takeshi Hatanaka from Japan. His title is Conversion Therapy for Unresectable Hepatocellular Carcinoma After Systemic Therapy. Dr. Hatanaka, please.
Thank you for your introduction. I'm Takeshi Hatanaka from Gunma Saiseikai Maibas Hospital. I thank you for Professor Shina to have opportunity to speak here. This is my COI. According to two pivotal randomized control trial, atezolizumab and bevacizumab were superior to sorafenib treatment in terms of overall survival and progression-free survival. And durvalumab and tremelimumab shows survival benefit compared to sorafenib treatment. To date, these two immunotherapy regimens were recommended for the first-line treatment for unresectable HCC. However, the complete response rate was 5.5% in the IMbrave trial and 3.1% in Himalaya trial. The rate of achieving complete response by immunotherapy alone is unsatisfactory. To address this issue, the conversion therapy is expected to promising treatment to extend survival in unresectable HCC. This slide shows a clinical outcome of conversion therapy from unresectable colorectal liver metastasis. Patients received downsizing chemotherapy and hepatic resection shows a better overall survival and disease-free survival. And this slide shows the previous studies reporting conversion therapy for HCC. To date, three studies were reported. However, the predict factors and the survival impact of conversion therapy remains unknown. So the present study is aimed to investigate the predict factors of conversion therapy in unresectable HCC. Additionally, we also elucidate the survival impact of conversion therapy. And among 961 HCC patients treated with atezolizumab in our affiliated hospitals, a total of 946 patients were included in the present study. They are divided into two groups based on whether they received conversion therapy, a conversion group and a non-conversion group. A conversion therapy was defined as any local regional treatment with curative intent after achieving tumor shrinkage with atezolizumab. Cases were excluded from conversion therapy if they achieved a complete response according to RECIST version 1.1 without any local regional treatment. A registered regression model was employed to identify predict factors associated with conversion therapy. To minimize multicollinearity and overfitting, the number of explanatory variables included in each model was limited to 4. A landmark analysis was used to minimize the risk of mortality bias, and multiple imputation model was implemented to address missing data. This slide shows a patient characteristics, and the median age was 74 years old, and about 80% were male in entire cohort. The performance status 0, 1, and 2 in 791 and 127 and 28 patients, respectively. About 50 patients were bio-related disease, and most patients were BCLC stage B or C, intermediate or advanced stage HCC. The significant difference in these two factors between the two groups were not observed. However, the BCLC stages were less advanced in conversion group compared to non-conversion group. About 19% patients had a Child-Pugh class A, and the median RB score was minus 2.41, and the MALB grade was 1, 2A, 2B, 3 in 336 and 244 and 331 and 15 patients, respectively. About 2/3 of patients received atezolizumab as a first-line treatment. The value of neutrophil lymphocyte rate is numerically less in conversion group compared to non-conversion group, but without statistical significance. About 20% had a microvascular invasion, and 30% patients had hepatic metastasis. The frequency of microvascular invasion or extrahepatic spread were less in conversion group to non-conversion group. This slide shows a tumor response. According to ASSIST modified RECIST, CR and PR and SD were in 6 and 28 and 9 patients in conversion group, while and CR, PR, SD, PD, and NE were in 49 and 256 and 31 and 164 and 124 patients, respectively. According to RECIST version 1.1, PR and SD were 28 patients, 20 and 15 patients, respectively. And in SD cases, in conversion group, tumor shows a tendency of shrinkage, but relatively limited, resulting in a determination of SD. As I mentioned before, the CR cases were included in non-conversion groups. As you can see, the object response rate and the disease control rate was significantly higher in conversion group compared to non-conversion group. And the median interval between the initiation of atezolizumab and the date of conversion therapy was 8.6 months. We compared the overall survival in the conversion and the non-conversion group. The median OS in conversion group was not reached, while it was 20.4 months in non-conversion group. As you can see, a conversion group shows better survival compared to non-conversion group. This slide shows the details of the conversion therapy. Surgical resection and ablation and TACE and radiation therapy were received on 10 and 24 and 7 and 1 patients, respectively. Viable tissues were observed based on pathological findings in all cases that underwent surgical resection. In 11 cases, atezolizumab treatment was continued after conversion therapy. This slide shows OS according to the modalities of conversion therapy. As you can see, any treatment showed improved survival compared to the non-conversion group. This slide shows the predict factors associated with conversion therapy. BCS stage 0 or A or B, absence of microvascular invasion or extrahepatic spread, and low NLR is a significant factor associated with conversion therapy. Now, we conducted a comparative analysis of OS in the conversion group and the non-conversion achieving partial response. To investigate the additional impact of conversion therapy, we compare the conversion and the non-conversion groups, specifically focusing on the cases that achieve partial response according to RECIST version 1.1. We conducted landmark analysis at 6 months and 12 months and 18 months, and results show that the conversion group exhibited better survival compared to peer cases in the non-conversion group. As you can see, all three Kaplan-Meier curve, a conversion group is better survival compared to partial response cases. Next, we conducted a comparative analysis of OS in the conversion group and CR cases. We compared the conversion group, all patients in the conversion group, and achieving CR cases by RECIST version 1.1. This slide shows landmark analysis at 6 months and 12 months and 18 months. And the results show that the conversion group were comparable to CR cases assessed by RECIST version 1.1. So I think that OS in conversion group were comparable to CR cases. In discussion, the tumor response and OS were better in the conversion group compared to the non-conversion group. The predictive factors included B-cell stage B and absence of MV and EGS and low NLR. This suggests that the cases with less advanced stages were more likely to undergo conversion therapy. The cases with a low NLR were more likely to achieve a tumor response. This Kaplan-Meier curve shows OS in the conversion and non-conversion group. As I showed before, conversion group showed better survival compared to non-conversion group. However, the differences in OS attributed to a tumor response or to conversion therapy. Conversion group shows high tumor response and additional local regional treatment, while non-conversion group showed low tumor response. To investigate the impact of conversion therapy, we compared OS in conversion group and the non-conversion group, in both achieving a partial response. This graph represents the time on the horizontal and the tumor burden on the vertical axis. As you can see, tumor burden worsened in PD cases, and it remained relatively unchanged in SD cases, and improves in PR cases, and disappears entirely in CR cases. We compared the OS in the conversion group and achieving a partial response on the CR cases among non-conversion group. Conversion group were better survival compared to the PR cases and were comparable to the CR cases. In conclusion, cases with BCRC-B and the absence of microvascular invasion and hepatic spread, low NLR were more likely to undergo conversion therapy. The present study suggests that cases undergoing conversion therapy showed better survival compared to those achieving partial response. Additionally, conversion therapy, OS in patients with conversion therapy was comparable to those with a complete response. This is our group. Thank you for your attention.
Thank you, Dr. Hatanaka. Is there a question, please?
Beautiful study. A question. Do you do progression-free survival analysis between CR group and conversion group?
Thank you for your question. I didn't show this presentation. Disease-free progression. The differences between the two groups was not significant different. Not significant.
Yeah, actually, we saw cases with radiology CR, but pathology. We saw viable HCC when we do conversion surgery. That's the point.
In our cases, all patients shows viable tissue in pathological findings. So we didn't have a complete response based on evaluated by pathological findings.
Okay, thank you.
Is there any questions? Discuss now, Dr. Kuzuya?
Yeah, so thank you for your good presentation. So, in Japan, so we have most of patients are with a high age. So I recommend the patients receiving the conversion therapy if patients got a good tumor response by atezolizumab. However, elderly patients don't want to receive invasive treatment such as hepatic resection. So please tell me what percentage of patients can receive actually the conversion therapy?
Please, your question means hepatic resection is very invasive.
Yeah.
So
elderly patients don't want to receive conversion therapy such as hepatic resection. Yeah.
Thank you for your question. But your study, hepatic resection, OS was not significant different between the surgical resection and the radiation and the RFA and the TESS. But in my opinion, I think if the surgical resection is very invasive, radiofrequency ablation may be suitable for such a patient.
Thank you.
Is there any questions? For me, I have one question. Is there any common criteria for the conversion therapy in your study groups?
Pardon me?
I mean, is there any common criteria for conversion therapy in this group?
Yeah, thank you. We don't have a definite criteria for conversion groups, so it may be varied among the institutions. Yeah.
So there is a severe selection bias for this study because conversion group estimate, usually investigators estimate good prognosis, so they convert it to the dissection or RFA, right?
Yes, and I agree to your opinion.
Okay, there is no question. Thank you, Dr. Hatanaka.
Thank you.
Okay, let's move to the second presentation. Second presentation is Professor Ryosuke Tateishi from Tokyo University, Japan. His title is How to Choose the Right Research Question. Professor Tateishi, please.
It might be a title for APSL ASD workshop. So the true title is shown here. Thank you. Can I start my presentation?
Sure.
Yeah. Hello, everyone, and it's my great pleasure to be here and talk to you. And I would like to thank to the organizing committee, especially Dr. Shina, for inviting me to give this opportunity to talk to you. And as shown here, the title of my presentation, the role of ablation for hepatocellular carcinoma in the era of systemic therapy. And the title of this symposium is Can Drug Therapy and Classical Local Treatment Coexist? To answer this question, my answer is yes, of course. And I'd like to talk about the more conceptual topics rather than more specific topics. Today's my talk has two parts. The one is the rationale for local regional therapy in the CC treatment, and I would like to touch upon briefly the combination of local regional therapy and immunotherapy. All of you know the TNM classification. That was proposed more than 50 years ago by French surgeon Pierre Denot. He proposed this concept when the surgery was the only treatment for solid cancer, and there is no CT scan or no systemic therapy. The surgery is only possible treatment for cure of patients. As you know, T stands out for local extension of tumor, and N stands for lymph node metastasis, and M stands for distant metastasis. So even though the TNM classification has been revised so frequently, now the latest version is the eighth edition, but the key concept is the same. I'm so impressed to see that what such kind of concept survived for a long time, because it is quite fundamental. In any stages, the stage 1 corresponded to T1N0M0. In that moment, 15 years ago, maybe today, that may assure the cure of diseases by resection. And the stage 4 corresponded to any T, any M, and presence of metastasis that indicate the incurable tumor by resection or local ablation. I think that there is a dogma in cancer treatment that is localized to the, the malignancy can be classified into two parts. One is localized disease and the other is systemic disease. And local therapy is indicated for localized disease, and the systemic therapy is indicated for systemic disease. For example, this figure represents curable cancer. And the two, you can see the two Kaplan-Meier curves, and the curves, or both of the two curves, become plateau after 5 years. And as you look at the proportion of here and here, for example, in stage A or treatment A, 60% of patients got the cure, and cure of their malignancy. And on the other hand, 40% unfortunately did not get the cure, cured. And the difference between the A and B, treatment A and treatment B, or stage A and stage B, is a difference in terms of cure rate. So in those populations, the most representative indicator of the survival is 5-year survival, because after that, the curves become plateau. I'd like to show you a specific example of this type of Kaplan-Meier curve. This is from a randomized control trial on the gastric cancer. The authors performed gastrectomy with a D2 lymphadenectomy or D2 more extended D2 lymphadenectomy. So you can see on the left panel, the recurrence-free survival of both two treatments are identical. That may indicate the extension of the lymphadenectomy may not, improve, it may not increase the cure rate. Also, on the right panel, you can see that there is no difference in terms of overall survival. But if you look at the curves of the Kaplan-Meier, you can see the Kaplan-Meier, both two Kaplan-Meier curves became plateau after 5 or 6 years of the resection. And also you may notice that the two curves are quite similar, indicative of the survival after recurrence is quite poor, and recurrence after gastrectomy may indicate the incurable cancer. Another example is here. This Kaplan-Meier curves also indicate the incurable disease, though it's an exponential curve. The curve continued to decline after 5 or 7 months of introduction of systemic therapy or other treatments. And in this population, we all ordinarily indicate the hazard ratio or median survival time, MST. So for example, in this population, the median survival for treatment A or stage A is 6 months, and for stage B, the median survival is only 4 months. And you can calculate very easily to the difference is the ratio of the two treatment or stages, 1.5 or 0.677, indicative of a patient with stage A live 1.5 times longer than stage B. So this is an example of such kind of incurable cancer. This is from the systemic therapy randomized control trial for unresectable pancreatic cancer. There are two regimens. The one is gemcitabine plus cisplatin, and the other is gemcitabine. But unfortunately, these two are quite identical. But if you look at the curves, shape of the curve, this curve indicates that this is incurable cancer. You never see a plateau phenomenon on this treatment or on this population. So when we look at the survival curve after resection, this is from the 24th report on follow-up study of primary liver cancer by Liver Cancer Society Japan. And you can see here, it looks like became plateau, but it continued to decline even after 10 years of resection. Why? Because as shown here, HCC recurs very frequently after resection or ablation or any kind of local regional therapy because of frequent intrahepatic metastasis or de novo carcinogenesis from the from cirrhotic liver with high malignant potential, hepatocarcinogenetic potential. On the other hand, extrahepatic metastasis is rather infrequent in HCC. This slide shows the two studies from our institution. On the left panel, you can see the cumulative incidence of extrahepatic metastasis after a curative ablation. We repeated the ablation when it is indicated for recurrent HCC, and when we calculate the cumulative rates of extrahepatic metastasis, that is only 20% in 10 years, indicative the 2 years annually incidence of extrahepatic metastasis during repeated radiofrequency ablation. The right panel, you can see the recurrence rates after initial radiofrequency ablation. The recurrence type are categorized into two parts. The one is intrahepatic recurrence, the other is extrahepatic recurrence. And you can see the extrahepatic recurrence is quite rare after initial treatment of radiofrequency ablation to HCC. So that is quite different from other cancers like a gastric cancer or a colorectal cancer. So we can repeat local regional therapy unless there is emergence of extrahepatic metastasis or portal vein invasion. When you look at the reablation rate in our institution, so as shown in the previous slide, the recurrence is quite frequent after curative, locally curative ablation. However, we can perform the 80 to 90% of population with recurrence repeatedly, shown here. And if you look at the percentage of curative ablation rate, and you can see that even after 6 recurrence, we can perform radiofrequency ablation in 80% of those population. The similar phenomena we can see in repeated TSCE. This is a patient with multiple HCC who were treated by frequent 17 times of TSCE during 11 years. And this curve shows the value of AFP value. And you can, when I transform the y-axis into logarithmic axis, you can see that there is a linear trend that indicative of exponential growth of AFP during the repeated treatment. Also, you can see that each treatment may prolong the survival of patients. AFP value in this case indicate the tumor burden. So repeated tumor ablation or TSCE decrease the tumor burden and extend the survival of patients. And when you look at this proportion, this treatment, after this treatment, AFP value decline and increase in 6 months. So it might be said that this treatment extends the 6 months of survival in this patient. So we repeat the local regional therapy to extend. That is incurable, but in HCC, we can extend the survival by repeated local therapy. That is a bit different concept, as I shown in the previous slide, because the localized therapy for localized tumor, systemic therapy is a systemic disease. But it's in between these two, because the intrahepatic metastasis may indicate this widely spread tumor to the liver, but we can repeat the locally curable tumor ablation to extend the liver to its patient with liver HCC. And also, this is a concept of debulking surgery or debulking treatment. One treatment may, this patient may have a doubling time of his or her tumor with 1 month. So one treatment reduced when the one treatment reduced the tumor burden to a quarter, that may extend the 2 doubling time of the survival. One exception in the treatment of HCC is liver transplantation. You can see here the recurrence-free survival and the overall survival after liver transplantation. And the survival curves were stratified according to the stages, beyond Milan or 55500 rules. Anyway, you can see the plateau phenomenon on both of the two curves. And again, you may notice that the two curves are quite similar, indicating the poor prognosis after the recurrence of HCC after liver transplantation. That is quite similar in gastric cancer cases, as I shown in the previous slide. So in the summary of the first part, although local regional treatment, except for liver transplantation, are non-curative for most patients, but repeated local regional treatment can prolong survival. That is a key concept of our treatment strategy for HCC. I think that there are 2 points regarding the tumor progression or tumor staging of HCC. On the right hand, you can see that there is, of course, the technical aspects. The tumor stage or tumor distribution determines the indication of resection or local ablation or TSCE. Because when patient has 3 tumors differently distributed disseminate to the different segments, to perform the resection is more difficult compared to cases with limited tumors in the limited segment. In such case, you can only just segmentectomy to remove 3 of these tumors. But when the tumor is scattered from the whole to the whole liver, it's quite difficult to resect the patient, especially when the patient has a liver cirrhosis. On the other hand, radiofrequency ablation can be performed to 3 or maybe 4 or 5 tumors when the tumor is quite small. However, when the tumor is 5 centimeters, 7 centimeters in diameter, it's a bit difficult to get the local cure. So the tumor distribution and the tumor size determines the tumor indication. On the other hand, as you know, in the Milan criteria, quite famous criteria for liver transplantation, the criteria include the 5 centimeter single nodule or smaller than 3 centimeter or with 2 or 3 nodules. That is a criteria for local cure. That is not true because you can resect the whole liver. So any kind of tumor number or any kind of tumor size you can resect unless there is an extrahepatic metastasis or vascular invasion. Why this indicate this criteria works so better? So because the tumor size and tumor number also indicate the differentiation or malignant potential of tumor itself. So sometimes we confuse the two concepts because both of them, we are considering every day, and sometimes we confuse these two. But we need to think about the concept. This is a Japanese clinical guideline for HCC, and this is APSL treatment algorithm for HCC. These two are similar, and the key concept is such: the treatment, the tumor stage indicate tumor extension indicate the tumor treatment, and it determines the feasibility of treatment. Also, you can expect a better survival on the left panel, on the left side of the treatment, because the tumor differentiation might be good, better than the patients on the right side. These days, there might be, again, also the topic of today's seminar, today's symposium is that, we need to combine these treatments. What is the rationale for the combination? As I said, and in the first part of my talk, I think it may work because except for liver transplantation, any kind of treatment for HCC can be regarded as a debulking surgery or debulking treatment to extend the lifetime of patients. There are arguments regarding the neoadjuvant, adjuvant, and conversion, especially after the emergence of atezolizumab, bevacizumab, because that we can expect a true shrinkage of the liver that may expand the indication of resection. There are so many discussions regarding, and many societies are now working on the definition of the resectable, unresectable, and borderline resectable patients. And the key concept is shown here that for adjuvant therapy, the major purpose of adjuvant therapy is to improve the cure rate, especially for breast cancer. Adjuvant therapy does work to increase the cure rate. However, I'm not sure how the adjuvant therapy in HCC may increase the true cure rate because anyway as I mentioned so frequently, repeatedly, the tumor treatment for HCC is fundamentally debulking. On the other hand, neoadjuvant therapy also increases the resectability when the tumor is adjacent to the major vessels, and when after treatment of immunotherapy or other systemic therapy, when you observe that the tumor is apart from the major vessel, the resectability might be increased. Also, as talked in the previous speaker, there is an argument regarding the conversion therapy. a major target is unresectable patients. When the patient got, good tumor response after systemic therapy, you might consider the conversion or combination therapy. We need, I think that we need more time to, stratify or, get the true definition regarding this kind of discussion. But we need to clarify what is the discussion point. And also I can see, I found this kind of proposal by hepatologist in United States. And also you can see the resectability and borderline resectable. And that is, in borderline resectable, there is a bit extended tumor. That some surgeons may think this is resectable because it is technically resectable, but the prognosis might not be so good. So I'd like to briefly touch upon the rationale for immune checkpoint inhibitor combined with local regional therapy, because the local regional therapy, including radiofrequency ablation, DSE, or cryoablation, the microwave ablation, or radiation, may change the non-inflamed tumor to be inflamed tumor. That might increase the effectiveness of immunotherapy or combined immunotherapy. And there are preclinical or early stage clinical study to suggest this kind of synergistic effect of local regional therapy and systemic immunotherapy. However, there is not so much papers, not so many papers truly prove the possibility of the combination. I found this phase 1-2 study to prove the concept. They enrolled the patient with relatively advanced disease to they ablate tumors, limited regions, because when you ablate all of the regions, you cannot evaluate the effect of systemic therapy. Then they combined with ablation with toripalimab, that is an anti-PD-1 agent. The study results show the ablation prolonged the duration of response of systemic therapy. That might be not a strong proof of concept, but I would expect there are many papers or agree to or not agree to this concept. And there are so many ongoing trials shown here. The result of some of them recently appeared. But we should continue to pursue the possibility of this kind of concept based on the clinical trials, of course, randomized clinical trials. And I think that there is still questions to be answered remain. What is the preferred local regional therapy? These are, for example, radiofrequency ablation, microwave ablation, cryoablation, or IRE, sorry, DSE. They can provide the necrosis of tumor. However, the immunogenic effect is so different among the ablation therapy. So we need to understand the immunogenic effect of those kind of ablation by maybe animal model or by biopsy samples or other kind of experiment. And first of all, does local regional therapy enhance the effect of immunotherapy truly? Because some reports suggest that extensive surgery accelerated recurrence. That is not a good news for surgeons and those who are considering the adjuvant therapy, because the liver needs to proliferate, to be enlarged after resection. There might be some cytokines that may enhance the tumor progression. Also, in early era of ablation therapy, we have seen several reports indicative of accelerated malignancy after ablation. So we need to consider this point when we consider we are thinking about the combination of ablation. And also, atezolizumab, bevacizumab have a good tumor effect, but sometimes I think that this effect is solely by the bevacizumab, not by atezolizumab, because that tumor turns out to be black, but the tumor did not, does not shrink. And we need to consider, though not always the bevacizumab has a synergistic effect to increase the effect of the atezolizumab or other immune checkpoint inhibitor. And finally, does the prolongation of PFS leads to the prolongation of OS? This is an example of metastasis from colorectal cancer resected by surgeons in Japan. They performed a randomized controlled trial to stratify these patients with adjuvant therapy and placebo. And this is indicative of the red line indicate the chemotherapy group, adjuvant therapy group, shows the better disease-free survival. However, as is shown in the right panel, the better PFS did not lead to overall survival, because I think that this adjuvant therapy may not increase the cure rate, may prolong the survival, but that did not increase the cure rate. So we need to consider this key concept. So in summary, further research is needed to find the appropriate combination of systemic therapy and local regional therapy. Thank you for your attention.
Thank you, Professor Tateishi. Is there any question from floor? Okay, please.
Yeah, I like the concept you have mentioned about the serial debulking of the tumor by some local regional therapy, which have been shown to improve the survival. I agree with you, especially for those patients with small size to moderate size. But in my experience in the liver HCC, the liver is cirrhotic. Usually one of the limiting factors, we can apply multiple local regional therapy is limited by the liver reserves. And also we know that especially when you give multiple TACE long selectively, it's going to damage the hepatic function, leading to worse LB grade. So I would like to ask your question is, do we need to consider, apart from the tumoricidal effect of the local regional therapy, how could we preserve the hepatic function? By giving as limited treatment or reasonable number of treatment is also important. In that sense, I think it makes sense to give some neoadjuvant systemic, which can reduce the frequency of the multiple local regional therapy. Thank you.
Thank you. That is, I totally agree with you, because that is a key concept. We need to balance between the liver reserve, functional reserve, and the local cure, or the effect of debulking the tumor. We have struggled for the last 3 decades to balance, to find the true answer, but it's quite complicated, and I couldn't standardize the mode of treatment strategy in specific cases. That you can see on the algorithm, it's quite simple. You can choose, quite easily, but in reality, it's not so. It does not work, because at the tumor location, or you start the tumor located on the surface of the tumor or in the center of the tumor. Even though the time size of the tumor is the same, the effect to the liver parenchyma is also different. So I don't have a true clear answer to your question, but I'd like to emphasize that we need to consider the balance, and depends on for example, etiology of HCC. For example, you can perform the DAA treatment for HCC patients, and you can also do nucleoside analog treatment for HBV patients. We published a paper, proving that these kind of antiviral treatment can prolong the survival of patients, because that the treatment can improve the liver function. And when the patient is not indicative of liver transplantation because of shortage of organ donor or old age, we still should consider the balance between the liver function and local cure. Thank you.
Okay. Dr. Kuzia,
Yeah.
do you have a...
Thank you for your good lecture. Yeah. So you mentioned the high recurrence rate after the curative therapy in HCC patients. So do you believe in the long tail plateau in patients who got a complete response by the systemic therapy?
That's a good point. As I mentioned, but in some cases, immune checkpoint inhibitor provide the patient of, maybe permanent cure of cancer, especially when we confirm the pathological response by resected specimen. And the patient might live longer than 5 years without recurrence. That is a new, emerging treatment that was never seen in the 5 years ago. So we expect when we improve the recurrence, improve the effectiveness of immunotherapy or combined immunotherapy, we may expect the total cure of patients in the future. Thank you.
Okay, is there any question? Okay, thank you, Dr. Tateishi. Okay, let's move to the third speaker. Third speaker is Professor Stefan Lam Chan from Hong Kong SAR, China. His title is TACE plus Systemic Therapy, How and Who? Okay, please.
Thank you, Chairman. I would also like to thank Professor Shina and also EPASO for inviting me to speak on this topic. I chose the TAC plus systemic therapy, how and who, because I think this will be of interest, not only to the oncologists, hepatologists, but also to our IR colleagues or even surgeons. So these are my disclosures. So in the next 15 minutes of time, I will give you a very brief background on why do we need to combine systemic therapy with the TACE. And the next is what are the data to guide us how to combine. And last but not least, I will talk about who will be benefit most from this approach. About the background, back to basic, we know that TACE has been established as a standard treatment for the intermediate stage HCC. But if you look at the history of the development of the data for TACE, it's not as straightforward as you think. A total 7 randomized trials have been conducted, only 2 positive studies. There have been around 4 meta-analyses, 3 of them showed survival benefit of the TACE. And when you look at these 2 positive phase 3 or randomized study, you can see the 1-year, 2-year survival rate is a bit different between the 2 studies. So what is the implication? The implication is actually the TACE population is very heterogeneous. Whether your trials will be positive or very positive or even negative, depend how or which patient you chose for your clinical trial. If you focus on this population with a reasonable disease burden and also absence of any vascular invasion, good liver function, ECOG performance status of 0, of course, you have a very good outcome. And this usually group as the BCLC B or intermediate stage HCC. And if in the real world, you know that TAC very large tumor, patient with borderline features, even with invasion of branch or portal vein, or even suboptimal liver function to start with, you will have a lower response rate and the worst overall survival. So when we talk about improving the outcomes of TACE, one hand, we need to carefully select our patients. Today, I will not elaborate too much. We know that already we can select based on beyond up to 7 criteria. In UK, in Europe, they sometimes talk about the HAP score. Basically, all these are helping us to give a system to judge the liver function, disease burden, and also the vascular invasion to guide us which patient will have a best benefit or best survival from the TACE. But of course, we can also talk about adding the systemic therapy. So what are the data on the combination of the TACE with the systemic therapy? First of all, I think we all have experiences or look at some of the data on the TACE plus the multi-targeted, mainly the VEGFR TKI, like plus sorafenib, brimonib, axitinib, and the lenvatinib. I'm not going to bore you with all these data. I think overall, our experience is that based on randomized study or some of the single-arm study, there have been lack of significant synergism to improve the outcome of the patients. Maybe a little bit PFS, but definitely not OS when you compare to the TACE arm. We know that recently we have seen one China study, long study comparing TACE plus lenvatinib versus the lenvatinib, which shown to improve PFS and OS. I'm going to touch a bit on this data later. But perhaps I would like to, I'm biased, I show you some of our own experience. We actually reported and completed this study, a phase 2 study, on the combination of TACE with axitinib. For your information, axitinib is a very potent VEGFR1, 2, 3 inhibitors in the treatment of inoperable HCC. So what was our experience? As this is the study design. We have a TACE period with maximally 6 cycles of TACE within 1 year time. And then afterward, we put the patient on maintenance axitinib. And during this TACE period, we also gave the axitinib before and after the TACE. We hope to give an anti-angiogenic combo with axitinib on top of the TACE. So what was the experience? Let me share with you this case. In fact, this is our first patient. This patient has very big tumor. You know, actually it's probably advanced stage rather than in the middle stage. And then after just 1 cycle of the TACE, and then we gave the axitinib as well. In fact, the tumor became very necrotic. You can see and also there's some rim of Lipardo stain. So we are very happy at that time. Oh, this is a very good regimen. But then we know that after another cycle of TACE, the patient had recurrence just after the TACE. And then we know that the effect of this anti-angiogenic effect is not going to be long-lasting. So in this study, we end up with an OS around 18.8 months, not very exciting. This is why this was not pursued further into the phase 3 or randomized study. So I think this is our experience. Probably when you put just TKI alone, it's not going to be durable. And this is, as I mentioned, the LARM study. Actually, it's a positive study in terms of overall survival and also the PFS. Actually, the 2 curves separated widely. But you can see most of although it was published in JCO, in different meetings, especially in the West, many Western doctors, they don't like that because the concept of inoperable or advanced HCC is a bit different between China and also the Western part of the world. There have been both the BCLC B and also C. So they don't know whether which type of population are they targeting at. And also, there's some criticism that the control arm should be TACE for those patients with more intrahepatic disease burden. But I think this is still a kind of study showing that in this group of patients, despite the heterogeneity, the combination of TKI, a potent TKI, has some synergism with the TACE. But of course, nowadays, the wave, as mentioned by the previous speaker, is moving towards the IO plus the anti-VEGF. And I agree that it makes sense from the rational point of view, because we know that the TACE could induce the cytotoxic tumor cell death, and this will lead to release of the tumor antigens. And we know that this could theoretically stimulate the T cell activation. And when we add the anti-PD-1 or PD-L1, it will be synergistic. And of course, we know that TACE could induce the systemic increase in the VEGF levels. And also we know that adding anti-VEGF like a T-cell story could potentially also improve the immunosurveillance of the anti-PD-1 and PD-L1. So this is the study. I think everyone is familiar. So I'm not going to go through the details of this IMerate-1 study. I would like to try to draw your attention to 2 points. First of all, this is a study not only purely on intermediate stage, because when they designed this study, they want to mimic the real-world practice of the TCE. So they also included patients with VP1 and VP2. But the patient must not have the extra hepatic disease involvement. So kind of intermediate stage plus some advanced stage patients. And also it's a complicated study. There are 2 phases. In the first, in the TACE phase, within 16 weeks, the investigators are allowed to give TACE as they want, but with a maximum number of 4 cycles of TACE. So you can give 1, 2, 3, 4 within 16 weeks, and with the durvalumab or the placebo. And then afterwards, one arm is durva plus placebo, and the other arm is durva plus bev as a maintenance. Of course, another arm is the placebo and placebo. So I'm not going to bore you with a lot of details of this IMerate-1 study, but I think this is the take-home message the investigator wants to show us, is that when we compare the primary endpoint, which is the median progression-free survival, the durva, bev plus TAC arm is better than the placebo TAC arm, with a hazard ratio reasonable, 0.77, and also you're talking about nearly 7 months of the improvement of the PFS. So unlikely this is due to a chance finding. There must be something happening favoring the treatment arm. Of course, I try to be critical of this study. Everyone agrees that we need to look at the overall survival, although I would argue the overall survival will be diluted by the effect of the subsequent line of therapy, many lines of systemic therapy. To me, I think more meaningful is to look at the long-term survival rate, especially when we try to advance the use of systemic therapy in such an earlier setting with TACE. Even we don't see median overall survival benefit, we need to see a proportion of patients getting cured or long-term survival based on this combination. And also, there's one data they have not presented in the ASCO GI, which is the safety, not during the whole study, but during the TACE phase. We know that when you combine BAF and also PD-1 with TACE, sometimes it can be problematic. So I think they should present some of the safety data during TACE, which I think they will present later in some conferences. Also, there's some suggestion that maybe this study will be more powerful if there's a control arm of systemic therapy rather than the TACE. But fortunately, we know that there's some other study comparing the systemic to the TACE alone. But anyway, these are some of the further thoughts that stimulated by this IMerate-1 study. And also, we know there will be also some other study looking at the combination of TACE with the systemic IO-based treatment. Perhaps I would like to go to the last part of my talk, which is which population will be benefited most by this TACE plus systemic therapy approach. We know that we shouldn't focus too much on the subgroup analysis because these are more secondary analysis, and sometimes they're biased by chance finding and by the sample size. But sometimes we can still get some idea from this pre-planned, especially subgroup analysis of this IMerate-1 study. So perhaps you can see overall, the curve, the forest plot is the hazard ratio on the left-hand side, which is suggestive of the fact that all patient subgroups seem to benefit from the TACE plus durva and the bevacizumab. Especially, interestingly, when you look at the beyond up to 7 criteria, they're supposed not benefited most from the TACE, but then they still have benefit. Even you look at the presence of the portal vein invasion or the B-cell C stage, etiology, even HAP score, it seems to tell us that, don't worry, just give the TACE plus systemic to anyone. And also when you look at the subgroup analysis, pre-planned analysis of the large studies published in the JCO, again, you can see overall the curve is over the left-hand side. And all these are telling us that maybe it's good to give systemic plus TC to all patients. So do you believe in this story? Do you believe that one size fits all? Perhaps our clinical sense tells that probably is not that straightforward. If you try to look at the patient disposition of the IMerge-1 study, I would like to draw your attention to the number of the TCE procedures. Interestingly, although the investigators, very experienced, they are allowed to give many cycles, up to 4 within 16 weeks. You can see most of the patients, 60 or 60 patients, they only received 2 cycles of TCE, and in fact, more than 80%, they only received 3 cycles of the TCE. So what is the implication? The implication is that the intrahepatic disease burden probably is not as huge as we think in these phase 3 IMerge-1 study. Most of the investigators, they think just 1 or 2 cycles, they can control the intrahepatic disease burden already. I think this is also an important concept, is that when we give TACE, as I mentioned, organ preservation is important. In the old days, because we do not have systemic therapy, we always give palliative TACE, numerously, many cycles, repeatedly to our patient. And now we have numerous data showing that this is harmful to our patient because you are damaging the hepatic function. And nowadays, we focus on giving selective TACE, try to only give TACE to a small area through the super selective technique instead of giving the TACE through unselectively through the uncommon hepatic artery. And this is important because you can preserve the hepatic function, you can focus and improve the local response rate for the HCC. And I guess this is the case in the IMerge-1 study. Although they recruit patients with advanced disease, but when they select the patient, the intrahepatic disease burden, even beyond up to 7, is not that high burdened. Of course, I would suggest the AstraZeneca to conduct more granularity on assessment of the disease burden. But I think when we try to use this approach of TCE plus systemic, it's important to focus on the intrahepatic disease burden. And this is also another data, I think, published by Professor Kudo, that just look at the TACE versus lenvatinib, and those patients beyond up to 7. If you keep TACing the patient, this can lead to worsening of the LB grade. Again, showing you that the preservation of hepatic function is important. So last but not least, I'm going to show you, of course, we have many guidelines by PASO, by AASLD, but recently, the ELCA also have a consensus guideline on the TCE. The key point is, apart from looking at those disease burden like B-cell C stage and also some of tumor board, TCE should be administered super selectively whenever possible. If in your tumor board you decide that the TCE could not be given super selectively, think of other treatment modality because this will be important to preserve the hepatic function. So i.e., in the future, we should look at the TCE to control those patients with reasonable disease burden, while those patients with large disease burden, maybe they should be better treated with some other modality, especially systemic therapy. So now we have 3 treatment modality. This is our conventional way. We give TCE first. If they fail, develop TCE refractoriness, then we move to systemic therapy. Of course, the IMerge-1 and probably other studies are going to tell us that you may give systemic together with the TACE. And now we also have a concept of TACE unsuitability, and there's some study also addressing this issue. If the patient have large disease burden, we can give systemic therapy. Which is the best? I don't know. My feeling is, we need more data. My feeling is, if you want to give TACE, still, apart from control of tumor, you should also consider the preservation of hepatic function. If the patient has reasonable disease burden, okay, give TACE. plus or minus systemic therapy. But if the burden is so high that you cannot give selective TACE, better consider this approach. I think this will be addressed by further like ABC study, by the global study and the replay study, which talk about the combination of systemic IO and TKI or the BEV versus the TACE. So ladies and gentlemen, this is my conclusion. First of all, I'm not saying TACE is not useful. It remains an important treatment for control of reasonable, not without selection, intrahepatic component. Outcome TACE heavily influenced by our patient characteristics. We need to select the right patient, not to giving TACE to all patients with an intrahepatic disease burden. And TACE plus TKI, I would argue that it has not achieved expected synergism, although the last study did suggest some synergism. I think the future will be the IO plus TACE plus the BEV or some other TKI. The IMMURATE-1 study, of course, we need to see the result of the study and the overall survival outcome. But there's no doubt that the differences between the intermediate stage and advanced stage HCC is going to be blurred. In the future, perhaps we need some combination of treatment in this group of the patients. So thank you very much for your attention. I look forward to answering your questions.
Thank you, Professor Chan. Is there any question from, please?
Very nice talk, Chana Jayasekaar, United States from the West. I had a question about the modality, the interventional radiology modality being TACE. In the United States, especially when you have large tumor burdens, particularly if there's portal vein thrombosis, the preference is to administer Y90 radioembolization, not even microwave ablation. So could you comment on the reasons behind TACE rather than Y90?
No, I think this is a very great question because I know in US, when we talk about IMMURATE-1, the IR people will say, this is not relevant to us because we already not using TACE, but Y90. We have used Y90 more than 20 years ago. At that time when Joseph Lau has done, and also Thomas Leung have done the Y90 within our group. Our experience is that generally Y90 is good for bigger tumor, I agree, and also but a solid tumor or small, the tumor more limited to one lobe. They are not good for those patients with multifocal HCC. You already have 2 to 3 nodules. When you do the dosimetry, when you do the TCMA scanning to determine how to give, you can give, but usually you need to divide the dose. In our experience, Y90 is perfect for those patients with big one-size tumor, but not good for patients with multifocal. I know there's some data by, I think, Dr. Salam on the portal vein thrombosis. I'm not a big fan of this because my feeling is, I think our last speaker have highlighted very nicely, when the patient has portal vein invasion, they tend to have more systemic disease. Actually, even you give Y90 very good response locally, they tend to have a systemic problem. But of course, I think in the future, there will be Y90 plus IO study. Hopefully, with result coming up, I'm not surprised there will be some patient who benefited from this approach. But as I mentioned, how to select the patient is a bit difficult. And I think TACE versus Y90, maybe the patient selection criteria is a bit different. This is so far my thoughts about this modality.
Thank you so much.
Thank you.
Please.
Thank you for your nice talk. I'm Chen Chunin from Taiwan Chang'an Memorial Hospital. I have one question. For the large tumor, if we want to use local regional therapy combined with systemic therapy, which one do you prefer? Or such as use TACE or radiotherapy or Y90? Radiotherapy, especially for the SPRT or proton therapy. Which one do you prefer?
I think it really depends on the MDT. I think all the modality is good, right? We also have radiation oncologists within our tumor board. They can tell us that if your tumor, even big, if the hepatic reserve is good, is on one side, they don't need to irradiate a large part of the liver. Sometimes you can also give radiation, or of course a Y90. I I think the HCC management is more complicated than we think. It's not that we can guide by EMERALD-1 study or just the BCLC, even a partial guideline. Finally, the tumor board is important. And yesterday we talked about the resources. I think still not many centers in even Asia can have offer the Y90 or even radiation. In that case, maybe TCE or plus or minus systemic is also important. So I don't have a magic number or magical experience to you. But so far, I think in Asia, if we see one big tumor without any satellite nodules, without too much vascular invasion, we are aggressive. We aim for downstaging. We aim for, as mentioned, conversion, rather than like the BCLC or just give palliative TACE. I think we tend to be very aggressive in that case, aiming for surgery or ablation for cure for the patient. I think this is a common among our Asian tumor board.
Thank you.
Okay, thank you, Professor Chen. Thank you. Okay, let's move to the last presentation. Last presentation data is Dr. Hidetoshi Nakagawa from Kansai University, Japan. Nakagawa Sensei, please.
Thank you, Chairman. I would like to thank Dr. Shino for inviting me, and I'm so glad to be here and happy to share with you our current research interest and our attempt. So first, I would like to clarify, our project is not adjuvant or neoadjuvant thing, but the combination therapy of radiofrequency ablation and immune checkpoint blockade for unresectable hepatocellular carcinoma. No COI. So as almost all of you may know, for last 2 decades, immune checkpoint blockade therapy for advanced cancer has been developed. And now in HCC area, we can use a couple of regimens for unresectable HCC. So as a result, many patients can benefit from those combination therapies, but still a lot of the rest of patients cannot benefit from these regimens. So we think there is a room to improve in those current immunotherapy. This is a typical abscopal effect case. This patient had the right breast cancer with multiple bone metastasis and lymph node metastasis. As a palliative treatment, this patient received irradiation on the breast and the femoral bone and lumbar vertebra. Although the irradiation area was very limited, only 3 part of the body, after radiation, this patient achieved a complete remission. This effect is called abscopal effect, which is supposed to be mediated by body immune responses or something. So in HCC area, we have reported that after radiofrequency ablation for early or very early HCC, RFA can generate the tumor-specific immune responses. In this study, we reported more than 60% of patients achieved the immune induction against tumors using tumor-associated antigen that we have identified, and using those peptides, I found the immune responses against those peptides. This is a kind of a limitation, and this is only for HLA-A24 patients. So now we anticipate the synergistic effect by radiofrequency ablation and the immune checkpoint blockade treatment. So in this study, I defined the abscopal effect by radio frequency ablation in murine models. Then go to early phase clinical trials using the combination therapy of RFA and the immune checkpoint blockade for unresectable hepatocellular carcinoma. First, I established the RFA treatment model in the mouse. I inoculated the MC38 colon cancer tumor subcutaneously. The tumor was exposed by cutting the skin and inserted the RF needle. We used the tips of the expander needles. Then I performed the radio frequency ablation. Tumor turned white, suggesting the nature of the tumor. This is the model. The mice got 2 tumors, and we performed RFA on one side and observed the opposite side. So result is here. After radio frequency ablation, this must get the slower growth of tumor. So we tested the same model in the different tumor types. This is a hepatoma BNL tumor model. Again, we could see the delayed tumor growth after radiofrequency ablation. So in summary, we can say RFA generated anti-tumor effects on the residual tumor in the murine models. So to further understand the mechanism of this effect, we first analyze the RFA-treated tumor. As you can see, in the RFA-treated tumor, there are increased infiltrate immune cells, including CD4, CD8, CD11C, which is probably dendritic cells, and the E480 positive cells, suggesting macrophages. If you go to the untreated observed tumor, you could see CD4 and CD8 positive cell infiltration were increased, whereas CD11B, CD11C, or NK1.1, there was no differences between these groups. So to further characterize the CD4 cells and the CD8 cells in terms of tumor specificity, we co-cultured lymphocytes with the tumor lysate, and we saw the tumor-specific responses were increased in RFA group, not only tumor-infiltrating lymphocytes, but also in splenocytes. So in summary, we could see CD4, CD8, or CD11C, and macrophages, F4AD increase in RFA-treated tumor. Then in untreated tumor, there were increased number of CD4 and CD8 cells, which was tumor specific. So to further understand the mechanism, we tested this treatment model in different experimental settings. Nude mice, which is T-cell deficient, canceled this RFA-induced anti-tumor effect completely, suggesting this effect is T-cell dependent. Whereas the clodonet liposome, which is a macrophage ablation model, didn't affect the anti-tumor immunity enhanced by the radiofrequency ablation. So next, we asked whether CD4 cells or CD8 cells actually works in this model. So to do that, we introduced the anti-CD4 depletion antibody or anti-CD8 depletion antibody in this system. Then observed in both depletion, the complete cancellation of the anti-tumor immunity. So because macrophage depletion didn't affect the anti-tumor immunity, so as to initiation of these immune responses, we thought the dendritic cells works an important role in this anti-tumor immunity model. This is in vitro assay of tumor uptake. So MC38 cells were dyed and heat treated, which is a mimic of radiofrequency ablation. Then co-cultured with bone marrow derived dendritic cells, then observed fragmented MC38 component was phagocytized by dendritic cells, whereas control MC38 still live cell cannot be phagocytized. So this is a kind of a side story of this approach. So to get further enhanced anti-tumor immunity, we transferred the exogenous dendritic cells after radiofrequency ablation, which leads to the further effect on the anti-tumor immunity. In this mice, we observed migrated dendritic cells in draining lymph nodes, suggesting the immune priming happens here. So let's go back to the original story. So in summary, radiofrequency ablation created enhanced anti-tumor immunity in murine models. The immune responses were initiated by dendritic cells, and they was mediated by CD4 and CD8 cells. So other groups also reported the efficacy of combination therapy of radiofrequency ablation and the anti-CTLA-4 antibody administration in mouse model. So now we plan to test in human this combination therapy of radiofrequency ablation and immune checkpoint blockade. So this trial consists of two cohorts. One is feasibility confirmation part and randomized cohort. We are now running this randomized cohort. Unfortunately, I cannot open the randomized cohort data for today, but feasibility confirmation cohort was done, and I can discuss with this data. So in feasibility confirmation cohort, which is done with 6 patients, inclusion criteria and the exclusion criteria are shown here. Namely, illustrated cases are applicable to this study. So we performed the radiofrequency ablation on one of the intrahepatic nodule and go to chemotherapy and observed the anti-tumor immunity. So this is an actual example case. So this patient had a number of nodules in liver. We targeted one nodule and performed the RFA, then achieved the complete ablation. Then go to the chemotherapy part and observed the rest of tumors. So this is the background of participants. We have 2 cases of cirrhosis out of 6 patients. All are BCLC class stage B and the Child-Pugh class A. 4 out of 6 patients already had the previous systemic treatment. So this is the result. We experienced the 2 severe proteinuria, which led to the discontinuation of bevacizumab, and mild adverse events, which didn't affect the treatment schedules. So with this data, we confirmed the feasibility and safety of the combination therapy. So we also checked the immune responses induced by this combination therapy. So this assay was for HLA-A24 positive patient. So 4 patients out of 6 patients were HLA-A24 positive. So we checked those 4 patients. As a result, 3 out of 4 patients showed any kind of immune induction targeting tumor associated antigen, which is very promising. Okay. In summary, we confirmed the feasibility and the safety of the combination therapy. 2 AEs that led to the discontinuation of drug were reported, and no adverse event due to radiofrequency ablation was reported. And also TA-specific immune responses were observed. Now we are running the randomized cohort. So in conclusion, we defined the abscopal effect in the murine models. We are now currently testing the efficacy of the combination of radiofrequency ablation and immune checkpoint blockade in the phase 2 clinical study. So I would like to thank all of my collaborators. Thank you for your attention.
Thank you, Dr. Nakagawa. Because it's a close time to this session, so I cannot accept any question, but he can ask on floor. Okay, I want to close this session. Thank you for your cooperation. Thank you.
Thank you, doctors.